Now, let's say that we are going to start the respiratory system. So, maybe if the age is 40 and it's a man and you can see the nicotine stain, what is the diagnosis? COPD. It's a very good thinking. So, rational thinking you started already. Let's say environment for treatment and complication. You look around, you find the sputum pot. Sputum pot. So that may be bronchiectasis. You saw the inhaler, that may be bronchial asthma. Or COPD also possible, some kind of an inhaler, steroid and mixed inhaler. So then you already go to wash, because when you are starting, when you are entering the room, actually you can immediately observe age, body, weight, sex. So if the patient is obese and short neck, of course obesity, hypoventilation syndrome if it is a girl, and if it is a man, there is obstructive sleep apnea. That's a very important comorbidities that can lead towards high blood pressure and cardiological morbidities as well. So if you report this, you will get very good marks. So you look at the environment for treatment and complication 2 times. Understand? So once when you are washing, okay, but when you are end of the bed, again start from etc. again. Because it can give you the diagnosis. Because you will not see this side. So start again from etc. When you finish this, wash your hand, introduction and pain, or do you have pain anywhere? And I'm going to check your, the lungs. Is it okay with you? If there is any pain, just let me know, I will stop for you, sir. So you are caring. So then you look for movement. Actually, movement is my definition, so you will not get it in clinical books. What I mean by movement is by me definitions, but it's just to make life easier. So in respiratory disease, the chest examination, there are 2 movements you must have to see. So when you are end of the bed, just ask the patient to actually take a deep breath through your mouth. Through mouth, someone have nasal obstruction, so it might not reflect the real lung. Understand? Through the mouth. So you see the lung movement, symmetry, chest movement is increase, decrease, or same. You could have a very good idea. So then you ask him to cough. So he give you cough. So if it is actually bronchiectatic, there will be crackling sound. If it is actually asthmatic, there will be actually feeling of wheezes. So that's how I can actually detect the diagnosis when I even talk with the patients. I don't need to take total history, but still you need to complete the history, so that, because our job is not to diagnose, our job is to, as I said again and again, DSC4. It's not only the diagnosis, it's just not managing the sickness only, because he might have plus. So still you need to go for beyond. But when you have a very pointed thinking, actually you will catch everything very quickly. Understand? So then the deformity, what kind of deformity is possible here? Of course, the COPD can have barrel chest. It's one of the most common deformity. So when now you do the percussion and obliteration of cardiac and hepatic dullness, it's a barrel chest. It's actually a COPD lung. You can be very confident. So then the deformity, what other deformity, pectus carinatum, pectus excavatum, these deformities we need to remember. If it is there, it will affect. But it may not be always. But the most common one will be, again, as I said, always need to remember epidemiology. Most common deformity in respiratory medicine will be barrel chest. After the deformity, the next thing you need to do is scar. Because if there is actually a scar mark down, it may be lung transplant. And if there is actually thoracotomy scar, it may be lobectomy, it may be total pneumonectomy. So it can give you the diagnosis very clear cut. And maybe there are some marks of, chest drain insertion in the angle of safety. You have to have a very sharp observation to understand that. So that all gives you the diagnosis. So never underestimate the proper exposure. When you are asked to do the respiratory examination, my rule is I will expose, I will see first, before I go for general examination. It may make the patient one time seated, but I will be very sweet. in talking. Oh, I'm sorry to make you sit upright, So then I will bypass some of the examiner's bad views. Why you are making again and again, eh? Because if I go for do fast, surface by surface, definitely I will forget. In exam stress, maybe many of you will forget, and at the end of the day, you will lose the battle. Actually, diagnosis is there. Then the sound, of course, wheezing sound, crackling sound, some are audible. You can actually feel that, especially the wheezing sound for respiratory examination. So the scar and sound, these two. Then any other swelling, right? Maybe lymph node enlargement can be seen if you are a sharp observer. Understand? So this is one of the relevant swelling and sign of systemic disease or syndrome. So what are the systemic disease here? Maybe the pleural effusion. What are others? Maybe the malignancy. So you need to find out the sign of pleural effusion and sign of malignancy. So pleural effusion can come as a part of generalized edema. Okay, so that means heart failure, all can come present with pleural effusion, or maybe it is coming as a part of infective process. So each have their own sign, think about it. And there is also the sign of malignancy, because maybe if it is very evident, patient may look a bit pale, but these days again and again, because we don't leave the patient unattended like that. So maybe patient will look still very little bit anemic. Because when we manage artificially, maybe we'll try to keep it 10. We will not try to fully correction. Is difficult because they have a very bottomless basket. The carcinogenic process will make always empty, right? So it's difficult. So maybe they will try to keep it 10, maybe a little bit pallor, but we will not give it to frank pallor because of the management. Understand? Because frank pallor will make the quality of life poor. So you have to associate these things again. So now really the exam starts. Actually, the respiratory system starts. So if my way of doing the respiratory examination is like that, I always see one thing at a time. So I start the inspection, so all this observation will be finished not more than 30 seconds. Everything will be finished. So the general examination, I will be looking at the hand first. Okay, so I will be looking at clubbing, I will be looking at cyanosis, I will be looking for warm palm, bounding pulse, plus and also the respiratory rate. This is actually part of general examination I will do. When I am doing the pulse, I will check the respiratory rate as well. Understand? So, and another one is washing of a small muscle of hand. Because in case of the lung cancer, it might happen. Okay, so these few things I will look at here only, general examination. So warm palm, bounding pulse, and confusion. This is a sign of carbon dioxide retention. Okay. So then I will go to the face. Okay. I will look for anemia jaundice as usual because that has some significance. Then I will oral cavity. I will just look for gum hypertrophy, nothing much. Okay. Then a neck. I will look just look. Because here GBP is not much important as in cardiovascular system. I'll just look at it, finish. I'm not going to do too much. So then actually the lymph node examination also carries some importance in respiratory system, right? So then I will go for tracheal position. I will go for chest expansion. Okay. I will go for percussion note. I will go for breath sound and vocal resonance. Okay. So lung is divided into upper lung, middle lung only in the right lobe, right side. So middle lung and lower lung. So I must have to remember where I can see what. You must have to follow the proper positioning. So here mid-clavicular line, mid-axillary line and posterior scapular line. You should be very accurately doing that. So now, the question is, based on this information, how can we differentiate respiratory disorders from the others? Tracheal position, chest expansion, percussion note, breath sound, and vocal resonance. Okay. So now the question is, number one thing you need to know that what are the common problem in the respiratory medicine. One is actually dull lung base. Okay. Another is crackles. So you must have to understand these two approach. How can I differentiate one from the others? So maybe today I will give you the grouping of the respiratory diseases based on the physical examination science. So the way I classify the respiratory disorder is, one is reduction group. Reduction group, what is that? The pleural effusion, okay, collapse, pneumonectomy, lobectomy, all are actually the reduction group. That means if you do the physical examination, you will see the percussion note dull, breath sound reduced, vocal resonance reduced. Understand? So the next is actually the consolidation group. And so that means infective, neoplastic and vascular. So these are the cause. So infection, that means the pneumonia, TB, right? Neoplasia means the lung cancer and metastasis, and vascular means pulmonary embolism. So if there is a consolidation, what will happen? Breath sound bronchial, okay, percussion note dull, vocal resonance increased. So vocal resonance is very important to me to detect, because it can be, its observable variation will be very less. Understand? So now the question is, there is another group of cases. Again, understand that collapse due to peripheral bronchus, collapse due to peripheral bronchus will behave like consolidation. The whole lung collapse will be like pleural effusion, everything reduced. Understand? But if you do an X-ray, you might find the diaphragm is uplifted. If it is a lower lung, lower lobe collapse. Understand? So now the next group is, I say hyperinflated lung disorders, maybe airway disorders, or let's say airway disorders. But it's not obstructive airway. So airway disorders, airway disorder group. So one is actually the hyperinflation of the chest. This is COPD. I already said how you can understand COPD. So here percussion note plays a tremendous role. If the obliteration of cardiac and hepatic dullness, this is COPD, most likely. Understand? So then the other group is actually, among the airway group, other group is bronchial asthma. Both of them will have prolonged expiratory phase in breath sound. Okay? So, based on breath sound and percussion note, you can very easily distinguish this is bronchial asthma, this is COPD. Clear cut? Very easily, without any investigation. Okay, let's go for the next. Clear cut?
Doctor, can you just repeat that? How do you differentiate COPD and bronchial asthma?
By looking at the breath sound and percussion note. Because both of them will have the prolonged expiratory phase. Right? Airway obstruction. Okay? So both of them will be, no, not bronchial breath sound, it's a prolonged expiratory phase. Consolidation will make the bronchial breath sound. Okay? And so the game is here, but bronchial asthma will not have this kind of, generally will not have this kind of, the obliteration of cardiac and hepatic dullness. Bronchial asthma is reversible. After the medicine, it becomes reversible, maybe in the middle normal. So, but COPD have the emphysematous change. When there is an emphysematous change, so it will happen. Understand? Obliteration of cardiac and hepatic dullness. Clear cut? Confident? Okay. So, now the next is actually the, still we are in the airway. One is airway obstruction, another one is airway dilatation. So what is airway dilatation? This is bronchiectasis. Dilatation, this is bronchiectasis. So when there is bronchiectasis, there will be coarse crepitations. That change character with coughing. Biphasic coarse crepitation. So if you don't ask the coughing, actually you lost the diagnosis. So the last group is airway. We said airway obstruction, airway dilatation. So that means here everything can be normal except this. So here the crackles will determine the diagnosis. So again, this is the KSI. KSI means knowing the keyword, sequence and importance of for each things. So this is the one like this. Now goes to the last part. Okay, the last part is fibrosis. Yes, again a localized fibrosis, maybe this area. Okay, fibrosis here will behave like consolidation. Understand? So if it is a big confluent fibrosis, will behave like consolidation. So it will fall in the consolidation category. But the thing that will actually make the fibrosis diagnosis very easy is the added sound. There are maybe diffuse fibrosis, there may be big area of fibrosis. So localized fibrosis will behave, localized fibrosis and localized collapse will behave like consolidation. Understand? But what make a diagnosis for fibrosis? If there is a fine and inspiratory crackles that doesn't change character with coughing. That doesn't change character with coughing. This is actually the diagnosis of fibrosis. So you can say this is fibrosis, fibrosis, fibrosis. Understand? So now again the KSI is fine and respiratory crackles. Okay? So now we discuss there will be some interstitial lung disease. Generally you cannot do anything. Maybe some crackles here and there, some interstitial pneumonia. That's why they are more asymptomatic. Because interstitium, the sound production will be very bad. Patient might have fever, sometimes it's difficult to detect. That's why. There might be less physical sign. Understand? But if there is a fibrosis, then there will be fine and respiratory crackles. So now is it clear? So from the dull lung based approach, actually vocal resonance play a very vital role to understand. And the crackles approach, coughing, asking for coughing, and actually of course all together, I'm not telling the coughing for the crackles approach, coughing and checking biphasic crackles that change character with coughing is bronchiectasis, and fine and inspiratory crackles that doesn't change character with coughing is fibrosis. Now, and actually there are very simple formula that can actually now help us to differentiate each from others. So, and there are situations that there can be overlapping. That means patient have bronchiectasis with pneumonia. It's off and on. How to understand that? When there is a biphasic coarse crackles along with features of pneumonia. So actually now you need to understand. So when you understand this, the basic understanding, so then you really will be able to, you will need to understand, dig more. Because I did not say, how can I differentiate this reduction group one from each other, right? We said pleural effusion, we said collapse, right? If then we said collapse, if the whole lung fibrosis, it will behave also like, so the pleural effusion, collapse, pneumonectomy, how to differentiate each from other? Can you say? Any idea? What will happen if there is a pneumonectomy or lobectomy? Sorry?
Vocal resonance reduced.
Think from the inspection. What will happen? Scar mark. So see, that's the diagnosis. Okay, if it is pleural effusion and collapse, how to distinguish? Think more beyond box and collapse. How to distinguish? Sorry? Breath sound, both will be reduced. How to distinguish still?
Between pleural effusion and collapse.
Yes. I say it is, let's say it's a big collapse, because big collapse will behave like pleural effusion, but segmented local, peripheral collapse, that means one area, one airway or 2-3 airway, big segmental airway gone, it will behave like consolidation. You have to understand this difference. But whole lung gone, this will behave like pleural effusion, because whole lung there is no sound, nothing. So, how to distinguish? What will be the position of trachea?
Non-fit.
And So see, these are the, so that means the observing the other parameters we can easily distinguish. So I think I should stop this lecture here.